Morning, everyone, and welcome. So, on behalf of the Division of Health, Wellness and Family Development and the Office of the County Medical Officer of Health, in collaboration with PHAO, the Pan American Health Organization, and UE, the University of the West Indies, I'd like to say a warm welcome to everyone. I'm very happy to see the turnout, and I think that speaks volumes as well, that we all know, and I'm sure everyone is aware by now, that there was the first confirmed case of COVID-19 in Trinidad and Tobago yesterday. So we've seen the panic buying starting, etc. And what we want to urge everyone is stay calm. The key is to stay informed, and that's what we're trying to do today, to make sure you're informed of what the risks actually are, and also what you need to do to protect yourselves and your family. So I'm not going to stay long because we have folks standing and it's going to be a while. So we're going to jump straight into it. Now, for today's session, to cater for persons who may not be able to attend, we're video recording this session. So for that purpose, when we have the question and answer segment, which will be after the two presentations, we ask that you wait till you're given a mic to ask your questions, right? So we won't field any questions in between. At the end of the two presentations, we'll field all questions. So first, I'd like to introduce Dr. Chris Oro, Professor of Veterinary Virology at the Faculty of Medical Sciences, University of the West Indies. Chris has been in Trinidad for 10 years, working on viruses that cross between animals and humans, and has been promoting the concept of One Health across the region. So I give you Professor Orr.
Okay, very, very good morning to everybody. It's always a great pleasure to be here on the beautiful island of Tobago. I'm sorry it's in these circumstances, which aren't ideal, but it's a great pleasure to be here. So I'm a virologist at the University of the West Indies, so I've been working on these types of viruses that we have here and we're going to talk about today for many years now, and I hope I'm going to get the opportunity to give you as much information as I can from a virus perspective, and my colleague Dr. Eldon Boisson will also talk about other aspects, so our talks should be very complementary, and then we'll have some questions at the end, which I think is a very important part of this, that you can get your questions across. It's very difficult to cover everything here. So at the top of each of my slides, I'm going to have a question, and I'm going to cover those questions because they're common questions that have come up about this virus, yeah? As you can see from these pictures, these are pictures of viruses that you and I know very well. Things like dengue, yeah, chikungunya, Ebola, Zika, yeah? And I show this slide to my students every year, and I say, what have all these viruses got in common? So I'm going to ask you, does anybody know what these viruses have all got in common? They've all come through animals, yeah? So this is what you call zoonotic viruses. They pass from animals to humans and back, yeah? And actually 3 out of 4 of the new and emerging viruses in humans, like this new coronaviruses, have come through animals. So this is not a surprise. This has been happening over many, many years. We get this drip through of viruses from animals to humans. So over the years, just as by way of a short introduction, I've been going at this talking about viruses for a long time now, and I remember in the 80s, people thought that we were on top of viruses. People thought we weren't going to get any more problems with viruses. And since that, we got HIV, and then we got a series of other viruses which we know about. And clearly, I regret to say that viruses are winning the battle at the moment. Why are viruses so good at winning the battle? It's because they change and adapt all the time to their circumstances. So when a virus changes, it's able to then jump species, or it's able to move from a virus that doesn't transmit very well to a virus that does transmit very well. So these viruses are really, really clever, yeah, because they're changing all the time. We also have a population at the moment where we have many of our populations are more susceptible. You know what susceptibility is all about, is about how strong our immune systems are, how we're able to respond to viruses. And there are many conditions that we have around at the moment that are affecting our immune system. So there's two variables here. There's variables in the virus and there's variables in the host. And what we're seeing at the moment around the world generally is we're seeing conditions that are conducive to viruses emerging and circulating very rapidly when they do. The globalization, the fact that we have planes coming from all around the world, bringing viruses with them, with people, the fact that we're living in close proximity to animals in many countries in the world, giving the opportunity for the viruses to jump. The fact that we have intensive agriculture that keeps animals in very, very close proximity to each other and to humans enables viruses to move very rapidly. And the fact that we're encroaching on forests, we're moving into areas like Ebola in Africa, where we haven't been before. So we're coming into contact with pathogens, and we're coming into contact with vectors, and we're coming into contact with bats that wouldn't normally come into contact with us. And then we're interacting with them, and then we're coming out. And there's a lot of features that are making this worse, like climate change, like poverty, like urbanization, like cutting down forests. So that's why we're seeing more of these viruses appearing. And when we get a new virus, like this new virus that we're here to talk about today, we need, in order to know how to put best practices in to control the virus, we need to understand a lot of things. We need to understand about the virus itself, because all viruses are different. They have different properties, yeah? We need to understand how efficient our host immune response is, how long we're immune for, yeah? Because some viruses you might be immune for only a few weeks or months, and some might be a year, and some might be for life. We have to understand whether we have, what type of immunity we produce. Because immunity is quite a complicated thing. You get different types. You get antibodies, you get T cells, you get neutralizing antibodies, you get all those things. We really need to understand that in order to be able to produce vaccines, the effective vaccines. And that's what we're doing at the moment. We're in the understanding phase, because this particular virus is a brand new virus. The other thing about these viruses we need to understand very quickly is how it's transmitted, because viruses are transmitted in very different ways. Some by close contact, droplets, some by airborne spread, some transplacental, like you know with Zika when you get the problems in the babies. You get all sorts of different ways, and you have to understand that again in order to control it. We also have to understand, as many of these viruses come from animals, they often have a reservoir where they have adapted and they're happy in, and that's usually an animal reservoir. And if you have an animal reservoir that the virus is able to go in, whatever you do in humans, you're always going to have that trickle through from the animals. It's always going to come back, yeah? So you have to understand that, because that significantly affects how easy or difficult a virus is to control. Vaccines are obviously critical, and as we're hearing about with this new coronavirus, health systems are really important. How strong are the health systems? Or how are we able to, what are we able to put in place? Do we have what's needed in order to best control and treat a virus? So moving on to the new coronavirus, which we're here to talk about today. This is a picture here, a beautiful virus, as you can see. You can say that some viruses are beautiful, and you can see around it these dots around the outside, yeah? Those are the spikes, the projections from the surface of the virus, and those are critical, because that's the interaction with the outside world. Those are like a key. They're like a key. Viruses have to enter a cell to infect anybody. and they enter a cell by like a lock and a key. So the virus has a key, and if it fits the lock on the cell, it gets in, and then if it infects the cell, it causes disease. And that key, if you can imagine, as a virus changes shape. And we all know when a key changes shape, it doesn't work. And the virus can't get in all of a sudden. Or the key changes and a virus can get in. And that's why, we hear about viruses that can, at one point, infect your upper respiratory tract cells, because it has a key that fits those. But then the virus changes, the key changes, and suddenly it can get into your cells right deep in your lungs, in the alveolar. And that's when it causes more severe symptoms like pneumonia, yeah? And it's all about those viruses changing and enabling them to make them manifest themselves in a new environment in the host. And that's what these viruses are doing. So, the coronaviruses. We all know, we've all heard about coronaviruses now. I teach about coronaviruses all the time. It's a very large group of viruses, a large family of viruses which infect many different species. There are human coronaviruses which cause the standard cold, our seasonal colds. They're caused by coronaviruses as well. We also have coronaviruses that affect all these animals you can see around the bottom of the slides. But in the middle section, you can see the red ones. And these are the ones that we're really interested in at the moment. That's SARS, MERS, and this new COVID-19. And they're all similar viruses. And you can see surrounded by them, if you can read the screen, there's a lot of bat viruses. These are viruses that have naturally infection in bats. And that's why we know that these viruses have probably come through bats, then likely to have come to humans. We can learn a lot from previous outbreaks of very similar viruses, yeah? We learn a lot from SARS and MERS. Probably some of you can remember SARS. It came in around 2002, and there was a lot of panic about it. And it spread around in many countries around the world. And the panic was, of course, it had what's called a case fatality rate, so of 10%. In other words, 10% of people who got the virus actually died of it, which was very high. But that virus wasn't very easily transmitted. So it was transmitted in small clusters, and then we managed to snuff it out by quarantining and standard measures. It wasn't very easily transmitted. Hence the importance of knowing how viruses are transmitted as to how easy it is to be able to snuff them out, yeah? MERS virus, which we've had for a while now, has an alarming case fatality rate of around 35%. So 35% of people who get MERS actually die of it. But luckily, again, it's very, very not easily transmitted at all. So not many people have got it, although it's coming through all the time because it's transmitted through camels. So in Saudi Arabia especially, people are getting it through direct contact with camels, but then luckily it's not being spread too much in the community on from there. So we have SARS that went from bats to civet cats to humans, and we have MERS that went from bats to camels to humans. And then when it gets into humans, the critical thing is how easy it is going to spread from there. And that's why we had to understand the transmission. This was what happened with SARS. Over around a 6-month period, it came and left. It was snuffed out. So we would love this to happen with this new virus, but because of the nature of this new virus and the fact that it's more easily transmitted than SARS, I'm afraid it's unlikely that it's going to come and go like this. That's why we need to understand how easily or difficult these viruses are transmitted. And with MERS, we've seen it continue, and the red is the case fatality, the yellow is the people that have it, so high levels of people dying, but not many people getting it. So what about this new one? Well, at the moment we know from looking at the genetic makeup of the virus itself that it's likely to have originated in bats. We also know that it's likely to have then jumped from bats to another animal, probably in that wet market in China, where there was close proximity to lots and lots of wildlife. And the wet markets in China aren't really very nice. Yeah, they're not. There's a lot of opportunities for viruses to jump, and then it's come into humans. And I've changed this slide. I've given this talk a few times, or similar talk, and I've changed this slide a lot because I had a big question mark just a few days ago or a few weeks ago about how significant the community spread was going to be, because we didn't know. We were hoping it would be able to be controlled. I took that question mark away, and then I had pandemic in the top right-hand corner, and I had a question mark next to it. And yesterday, I'm afraid I had to take that question mark away as well. And Dr. Boisson will talk more about how we define a pandemic. So we have this virus that's being spread. Dr. Boisson will talk about the clinical signs, more about the clinical signs and what you see. But I'm going to just mention briefly the risk factors and who is found to be being the most susceptible to this virus. And it's very important we understand this, because we have to target our health systems, we have to target our approach. And as you can see from this red across the top, with 80 people who are over 80 years, the elderly are far more susceptible to severe consequences of this virus than younger people. In fact, at the bottom, with kids from 0 to 9, as far as I'm aware, no children under 9 have died of this virus up to now, as far as I'm aware. So there are clear risk factors that we need to understand so we can prioritize and focus our health systems. And it's the elderly, and it's also people with underlying health conditions or comorbidities. And from China, from 44,000 cases, the first 44,000 cases in China, as you can see, they found the comorbidities that were the most significant were cardiovascular disease, where have I got it? Diabetes, respiratory disease, and hypertension. Okay, so the people with these conditions are more susceptible to the serious consequences, in other words, death from this virus. So it's very important to know it. It's also very important to understand with this virus, and Dr. Boisson will emphasize it as well, that the majority of people that get the virus are not going to get severely sick. Around 80% of people that get the virus are only going to notice relatively mild symptoms, not much worse than, say, flu, and in a lot of cases not as bad as flu. That's 80%. Then in the 20% was saying that there's about 15% that may need hospitalization, and it's only that top 5%, within that top 5% of people who are going to need more intensive care type hospital treatment. So how bad is it? Well, I know there was an article in the paper by a doctor yesterday saying that we're all going to get it. That's not true. We're not all going to get it. Viruses don't work like that. We have a thing called herd immunity, where the whole population doesn't get it. We don't quite know because it's different from virus to virus, but probably somewhere between 40 and 70% of people will get this virus. The other won't. If it spreads out of control, we won't all get it. That's important to note. And also the case fatality from the WHO at the moment is said to be 3.4%. That is what has happened up to now. However, in many countries that are managing this virus differently, or I would say more effectively than others, the case fatality, that's how many people die of the virus, is a lot lower. In South Korea at the moment, it's only 0.7%. The other thing that we need to be very aware of is what we call the denominator, is how many people are actually getting this virus. We still don't know whether there's a population of people that are asymptomatic, that are not being picked up. So they're getting the virus, but they're not presenting with clinical signs, and so they're not in the picture. And when you're measuring case fatality, you're looking at the amount of people that have died at the top, and you're looking at the amount of people that have got the virus at the bottom. And if you don't know the amount of people that have got the virus, that will change at the end of the day. So usually with these kind of epidemics, like with H1N1, the case fatality or rate is exaggerated towards the start of the outbreak, and as you move through and you understand it more and you're able to do antibody testing and really find out how many people have been infected, it goes down. So that's good news, yeah, that it won't be as bad at the end of the day in the case of how many people are going to die from it, as they're saying now. Let's keep our fingers crossed. But it's very, the other things that are really important about the case fatality is the availability of good health care. Because what we're finding here is people who are having severe symptoms like pneumonia, they're having to go into hospital, they're having to be given oxygen, they're having to be put on ventilators, yeah? So when you have access to those, people are surviving. But the problem is, as you're seeing in Italy and places like that at the moment, is there's just too many people that are entering hospitals and needing these kind of conditions. So you can't give everybody oxygen and ventilators, and I'll come to that a little bit at the end about what we need to do to try to not put stress on our health services or reduce the stress on our health services as much as possible. The population age structure is important. At the moment in Italy, a lot of people are dying, but Italy has a very large percentage of older people, so that might be causing it. The general population health and the incidence of comorbidities, as I've said to you before, that has an effect. In the Caribbean, we do have a lot of people with diabetes. We do have a lot of people with cardiovascular issues, so we have to be aware of that. How is the virus being transmitted is really critical as well. This is a respiratory virus, so as many of you know, if it's a respiratory virus, it's transmitted by coughing, by sneezing, and critically, what we see with respiratory viruses is different ways that it can be transmitted. Sometimes it can be like a short distance, i.e. droplet infection, so the droplets are produced when you sneeze and cough or when you speak, and then they're heavy, so they drop down onto a surface, and they don't stay in the air, yeah? They're not airborne. Some viruses, other viruses, they're airborne, so the droplets dry, and they stick around in the air, and they can be moved around in the wind or in air. This is droplet infection. Transmission, which means that it's a short space it's a short space that it's transmitted. So we have two things to think about. We have things about keeping away from that distance, which the droplets can be sneezed out before they fall down, and where they fall. Because the virus can stick around where it falls, yeah? And so if I sneeze on here, I touch my hand here, or somebody else touches their hand here, more to the point, they can then bring the virus to their mucous membranes in their face. It only gets in through those. Your mouth, your nose, your eyes. If you don't touch those, you won't get the virus as long as somebody hasn't sneezed all over you, yeah? But this is not an airborne virus, and that's why we will both be talking about, and Dr. Boisson will be talking about the importance of washing hands, the importance of keeping social distancing, those kind of things to stop the virus from coming in. So it's important you understand the way the virus is transmitted, especially in a hospital environment. If you enter a room and stand there, it won't just stay in the air and then be there to be breathed in by somebody else. But it might stay on surfaces if you've sneezed on them, so you need to disinfect the surfaces, yeah? That's important to understand. I'm going to finish up in a second. As I mentioned very briefly, how it survives, how long it survives. And there's quite a lot of work done on this with other viruses, but basically we think that this COVID-19 can survive on surfaces from a matter of hours to days. Not too many days, but we can't say exactly how long. It'll be different with the surface. It'll be different with where what it actually lands on. But it is going to be potentially there. So we need to disinfect surfaces because they are a potential source of the virus. So Dr. Boisson's going to talk a little bit more about what we need to do to stop to protect ourselves. And this is a very nice Ministry of Health information which you would have all seen. And I just wanted to finish off by talking a little bit, because I think this is really, really critical when we move into a state where the virus is circulating, which is likely to happen. We have to protect our health services like in this country, yeah, like in here in this hospital, yeah. We have to prioritize our health services for the people that need those health services, the elderly, the people who need. We don't want to have like a high peak that comes in and our health services are inundated. So what we need to do is we need to delay the virus as much as possible by the measures that we've talked about today. And if you can see by this graphic, if we delay the virus spread, we will then ensure that our health services won't be so stressed all at one time. And that's why we need to think about self-isolation. We need to take up all the recommendations of the Ministry of Health for hand hygiene, for social distancing, try to stop touching our hands and face. We need to start pumping our elbows rather than our hands. We need to take all these precautions when the virus is circulating so we slow its spread as much as possible. We don't, when it's spreading, the last thing we want to do is forget people, for all those people, those 80% of people who have mild infections, or the last thing we want those to come out and to come to to hospitals and to come to doctors and to come to our health centers. Yeah? We need a system whereby people phone up, people get advice, people stay at home. Yeah? Unless they have severe symptoms. Otherwise, we're going to be spreading these. You all know this, you're all working in the hospital. But this is something we need to get across to the public, yeah? Because otherwise, we will get this peak and we will put stress on our health services. If we can delay that peak, flatten that peak, we will get through this together far more efficiently. So I'm going to stop now, and I'm going to pass over to my colleague Aldona Boisson, who's going to take it forward from here.
All right, so just a reminder, we'll field questions at the end of the second presentation. So let me introduce Dr. Aldona Boisson. Aldona Boisson is an epidemiologist serving the Caribbean. She works with the Ministries of Health and other partners to provide technical support to national and regional programs in the areas of epidemiology, surveillance, statistics, outbreak investigation, and the production and dissemination of health information. In recent years, her main areas of focus have been on the implementation of the international health regulations in the English and Dutch-speaking Caribbean countries, strengthening influenza surveillance, and the development of a Caribbean regional field epidemiology and lab training program. She's been working with PHAO since 1998, where she still works as an advisor in disease surveillance and epidemiology. At this time, she's also one of the 30 PHAO WHO staff on the Regional Incident Management System team for COVID-19, serving as an alternate lead in the area of travel and health. You want to hold it?
Okay, good morning, everybody, and thanks for having us here, and thanks for coming out. So I'm going to continue from where Dr. Ora left off. He told you about the virus. It's important for you to understand that, for you to understand what your risk of infection is, and then be able to understand how best to protect yourselves. So quickly, I'll look at the current situation, a little bit about the symptoms, treatments, vaccine, and then be going into protective measures, debunking some myths, personal protective equipment, readiness of the hospital. So the global situation as at yesterday, and I would have done this updated last night, maybe at about 9 o'clock or so, and these numbers would have already changed. But a ballpark figure, we have 125,000 odd cases globally, and 4,613 deaths globally. Just to put that in a little perspective, for this flu season from like October to now, in the US alone, they have had more than 10,000 flu deaths. More than 10,000. And this is a good year. Some years they have as much as 60,000 deaths from flu. In the whole world, we have 4,613 deaths from COVID, just to put a little context. Most of the cases and deaths so far have been in China. Outside of China, of those 125 odd thousand, about 44,000 have been outside of China. About a quarter of the deaths outside of China, and most of the countries have cases, 117 countries. Zeroing in closer to home, again, this is of yesterday at 9 o'clock, and it would have already changed. But just to give you an idea that we do have spread in the Americas, we have 1,617 cases and 39 deaths. Closer to home, we see in Trinidad and Tobago, again, this is as of yesterday, 1, St. Vincent 1 in Guyana that died, Jamaica 2, and since that, they've had an additional set as well. And we have in North and South America too. To make it a little easier to see, if we look at the graphic here, the yellow circles are suspected cases. The bigger the circles, the more cases. And the red are confirmed cases. And as you can see, you have pretty much throughout the whole of North America confirmed cases, quite a lot in Central, South America, and the Caribbean. And we also have a lot of suspected cases. They're awaiting lab test results, and we will determine what proportion of them actually are cases of COVID. So it is moving fast. You heard from Dr. Ora that it spreads fairly easy from person to person, as does flu, as does common cold. I just want to give you a few definitions, some words that you may have heard, for you to have a better understanding what it means. So when this started early in January, this event was classed a grade 3 emergency response for WHO. All that means is that the affected country or countries require substantial response from the World Health Organization. So when you have these gradings of emergency by WHO, it is to tell us in WHO what level of response, what level of support we have to give to countries. Okay? Public health emergency of international concern. So a month after that, 30th of January, the World Health Organization Director General announced that COVID-19 was a public health emergency of international concern. What does that mean? Again, it has a strict definition. It's something that is deemed to be a public health risk to other states through international spread. So it's moving. You normally define it based on whether it's a serious event, or it's unexpected, or we have implications for travel and trade, or it may require some international action. Once it meets two of those 4 criteria, it is defined as a public health emergency of international concern. It does not relate to the severity of it necessarily. It speaks to this strict definition. How do we do it? Well, there's a roster of experts throughout the world in different areas. Whenever there has to be consideration of whether the WHO Director General is going to declare a public health event of international concern, relevant experts are pulled from the roster, and they look at all the evidence, and they so advise the Director General. Only the Director General declares a public health emergency of international concern, and this expert group also has to provide him or her with recommendations to give to countries in terms of what they should do. They're called temporary recommendations because we know things will change. And so the temporary recommendations may change over time. Pandemic. So Dr. Ora referred to it. So on the 11th of March, on Wednesday, again, the Director General of WHO declared COVID-19 a pandemic. It does not mean that it got more virulent or became a more dangerous pathogen. It's a geographical definition. It means that it is now a worldwide epidemic or outbreak. Epidemic or outbreak meaning we're seeing more cases than we expect. Since we never saw this before December, we were not expecting to see any. So once it hits a country, it is defined as an epidemic or an outbreak. So pandemic means that we have an epidemic everywhere in the world, and that's what it means. This is the first pandemic that we've had by a coronavirus, and we have actually never controlled a pandemic before. We've had H1N1 as a pandemic, and we have not taken these kinds of steps to try and control and to flatten that peak that you saw on Dr. Ora's last slide. So this is new territory for us. We're trying to do something that we had not done before. It's not just a health issue. Because of that, it needs a whole of government approach, a whole of society approach based on strategies to combat infection. So yes, health has to do what it has to do, but again, the general public have to do what we have to do, stay home when we're sick. I'm guilty that I don't always stay home if I'm sick. If I can struggle and get out and do what I have to do, I do. Maybe gender related, because, you know, the same thing I'd be running around with, my husband would be on his deathbed. But the aim really of what we have to do is to save lives and to minimize the impact. Reduce that curve so we do not have so many people getting ill. The symptoms. The most common ones: fever, tiredness, and dry cough. Additionally, some people will also be having aches and pains, nasal congestion, runny nose, sore throat. A minority of people will also have diarrhea. As I've described it there, you should recognize it, that it looks very similar to how the flu presents. Very, very similar. The symptoms, they don't just rush on you and you just can't breathe. Regardless of what you see in social media, it does not happen that way with background dramatic music. Symptoms usually start mild, as with flu, and then they gradually build up. Some infected people will not even get any symptoms. As we know with the flu, I might get the flu and I'm down for a day or two and I'm gone, back about my business. Somebody else gets it and they're knocked out for 2 weeks. Someone else gets it, they sneeze a few times and that's it. Same thing with COVID-19. How soon do you get it after you're infected? So let's say I was infected today. On average, most people will start to show symptoms, their fever and pains and runny nose and cough, about 5 days after. So before that, I'll be infected, but I won't show any symptoms. However, some people can show as early as 1 day after and as late as 14 days after. Okay? I want you to remember that as well when we think about spread, which I'll talk about in a little while. How it's spread, Dr. Ora told you, you cough or sneeze out the virus. So if you don't have symptoms, how is it getting out? And this is why we actually have no evidence to show that if somebody has no symptoms, even if the virus is in them, we have no evidence to show at this time that they can spread it to other people. And I would hazard a guess that if even at some point in the future that evidence comes up, the risk will be very small, because think of what you heard about how it's spread. I have to cough or sneeze it out. If I'm not coughing or sneezing it, it's going to be very difficult for me to be spreading it. Most people, about 80%, recover without needing medical treatment. They will probably just need to stay home for a few days, rest, and let it take its course. Maybe not even a few days. About 14% or so become severely ill. Some will have difficulty breathing if the virus goes down into their lungs. Again, who is more at risk? Older people who have a more fragile system, those with underlying medical conditions. I give you another example. In my family, I have 2 sons. One has exercise-induced asthma. He's a young, strong athlete otherwise. If we have flu at home, the other one does not have that. If we get flu in the house, my older son with exercise-induced asthma gets flu, and he has it for a couple days, I take him to the doctor. Why? Because I know he's more susceptible for it to go down to his lungs. The other one, young, strong, no asthma, he's rallying it out. He ain't going to no doctor right away because he's not susceptible. As is myself, I'm not going to run there after 2 days unless I find I'm having difficulty breathing. So it's the same thing that you would do with flu, that you would do with COVID. If you have elderly parents, for example, you would probably take them for health care before you take yourself. because you know you can better handle it. So it's the same thing with COVID-19. Be aware who's at risk and seek medical care for them early. Be aware of the symptoms. You have started difficulty breathing. That tells you it's moved down to the lungs. You need help. About 6% of people will fall into that category, needing some sort of critical care. And about 2% of the people, on average, depending where you are, as you saw, some more, some places more, some places less, about 2% of the people overall have died. Why it varies from country to country, you heard about aging populations, who has more underlying conditions, and so forth. Treatments and vaccines. You know, based on the first discussion, COVID-19 is a virus. Antibiotics target bacteria and kill bacteria. COVID-19 is not a bacteria, so antibiotics will not prevent. I know that is hard for you sometimes when patients come and you just tell them, you know, okay, it's a virus, ride it out, wash your hands, rest. They think, oh, well, I need pills. He didn't give me any pills. What's going on here? Try not to feel pressured. The pills will do them as good as Smarties. It will not tackle the virus. If hospitalized, however, as most of you will know, somebody may receive antibiotics because they may get a co-infection with bacteria. And so the antibiotics will be for the bacteria. In their fragile state, they may get co-infected. Vaccine, there's currently no vaccine. So the flu vaccine doesn't prevent. The pneumococcal vaccine doesn't prevent. That prevents against a bacteria that causes pneumonia, not the virus. So we don't have a vaccine. However, strongly advocating for you to take your flu vaccine because you can become infected with more than one disease at the same time. So if you can only tackle COVID and not flu at the same time, that's better for you. So still, get your flu vaccine. It won't help against COVID, but it will help against flu, and we're still in the flu season. There's currently no antiviral medication, unfortunately, so we do not have medications that will cure. However, we know how to treat symptoms. You saw the symptoms we spoke about. They are not foreign to you. We know how to treat those symptoms. We've had people with cough. We've had people with lower respiratory tract infections. We've had people with pneumonias. You know how to treat, to ventilate, and so forth. So people with serious illness, yes, they need to be hospitalized and receive the necessary supportive care. Of course, around the world, there are numerous places where they're doing research to find vaccines and treatment. This will not happen for tomorrow. Vaccines take a long time, a good maybe, 18 months before you get them. Why? They have to do the trials and make sure, one, they work, and two, that they are safe. So if you hear a vaccine has come out tomorrow, you probably don't want to be taking it, I'm guessing. You need to make sure, and they need to make sure, and it won't be on the market before that. But, so no cure, no vaccine, but we know how to treat the symptoms. We have no cure vaccine for dengue either, but we know how to treat the symptoms. So how do you protect? Dr. Ora referred to some of these. Frequently wash your hands with soap and water or alcohol-based rub. Why? If I go out and I happen to touch a surface with the virus, as long as I do not put my hand in my face on the mucous membranes, eyes, nose, and mouth. I saw somebody made one of those memes, an acronym, M-E-N, mouth, eyes, and nose. Stay away. Maybe half of you won't agree. But mouth, eyes, and nose, keep your hands away. If it's on your hands, you cannot become infected. It has to get in through those mucous membranes, okay? And I know when you hear that, immediately something starts to itch. But you restrain yourself till you go home and wash your hands, and then you could have a good scratch. All right? It's like when you see somebody with red eye, you want to scratch your eye, but you don't. If you don't put your hands in there, it can't get there. The other thing you don't want to do is to let people sneeze or cough on you if they're within a meter. So, and right now, if I'm here, if I had it, and I sneezed or coughed in a very unhygienic way with no tissue, probably these three ladies might be in problems. The rest of you are good because that's as far as it can go before it falls. The rest of you are fine. It cannot travel in the air. So you want to try and maintain a distance of about 1 meter if you see somebody sneezing and coughing, or, try give them a tissue. Avoid touching mouth, nose, and eyes. If you're ill, cover your cough or your sneeze with either the bend of your elbow or tissue and throw it away. A lot of people like to use a rag. No, then you end up with a ball full of virus. Use your tissue, throw it away. Stay home if you're not feeling well, if you have those symptoms. If you have fever, cough, any difficulty breathing, go seek medical care. Stay informed from reliable sources, not all social media. Stay informed of changes. Use of masks. So we're moving into some of the myths and how to protect. Well, people don't need masks, okay? I've just came back from traveling, and I see so many people, and they're like this, and they pull it across because they see somebody new, they give them a little kiss. Right? Waste of time. As a matter of fact, you're probably putting yourself more at risk because you're using your hands in your face and touching where you should not touch. Well people, I say it again, well people do not need masks of any kind. It is not useful and may put you more at risk. Masks are useful for people who have symptoms. So when they cough or sneeze, it stays inside. It's useful for people caring for ill people. Why? It's kind of hard to do that 1 meter away. You have to get in their personal space. Okay? So yes, it's useful for people providing care like yourselves. Irrational use of masks, spread the message. If people are using it irrationally, we're going to have a shortage. Some people already have. And then people like yourselves who need it to care for sick people will not have it. And then you get infected, you spread to more people. So by people misusing, they're putting themselves indirectly more at risk. Spread the word. Some mythbusters, again, spread the word. I don't know where some of these came from. These things do not prevent you from getting COVID. They do not cure you of COVID. It looks funny, but I kid you not, there's some people doing this. They may be good for other things, bush bath, bush tea, vitamin C, only the recommended dose. You take more, your body uses what it needs, the rest of it, you excrete. You're flushing your money down the toilet if you take quantum amounts. Zinc, hot toddies, I mean, it tastes good. Everybody likes rum, but it's not helping COVID. Garlic and other spices, again, I don't know where that came from. COVID, don't afraid, garlic. Keeping your mouth moist, well, now that you've heard what Dr. Ora said, it likes the moist mucus surfaces. This is like contrary to what you should think. So you're keeping it moist, making it a little nicer, all right? Using oils or gels in the nostril or in the body. So some people are saying, yeah, I just coat up with Vaseline every time before I go out and blow it out when I come. People are doing that. Not working. The virus is smarter than that. You heard it from the virologists. They're smart. Virus and oils, that's not helping. Disinfectant and bleach on the body? No. Surfaces, not body. Again, some people are doing and promoting this. Then you have people coming to your dermatology clinics. So again, spread the word. So how do you protect yourself? Again, I'll just say it again, it's so important. Wash your hands. It seems simple, but it works. After you cough or sneeze, when you're caring for sick people, before, during, after you prepare food, before you eat, after you use the toilet, if your hands are dirty, after handling animals, animal waste. It's what you should do anyway. It shouldn't be news. Protect others from getting sick. If you are sick, avoid close contact if you have cough and fever. Obviously, you don't go up in people's face and just sneeze on them. I mean, use a tissue. Avoid spitting in public. If you have fever, cough, difficulty breathing, seek medical care. Tell them about your travel history. That will help to ascertain, are you at risk of COVID or is this more likely to be flu? Cover your nose and mouth, when you cough and sneeze, throw away the tissue into a bin, not on the floor. Clean your hands, soap and water, alcohol-based rub. So I want to focus in on infection prevention control. This is what Dr. Hoyt said. In particular, here at the hospital, you need information on. I'm going to start with the aims and looking at risk, and then determine what you need to protect yourself. Just like now you understand the virus, when I spoke some of those myths, you laugh because you know better. There'll be more coming up. And if you understand the virus and you understand how it's spread, you'll be able to ascertain whether those things make any sense or not. So, infection prevention and control as it relates to COVID-19. What is it about? Why do we want to have infection prevention and control? We want to limit the spread from human to humans. We want to make the numbers of cases we get less so we don't overwhelm our systems, we don't get so many ill, we don't get so many dying. We want to reduce secondary infections, prevent that transmission and amplification and super spreading of the disease. Now, way back when did this all really start? Back in 1985, when HIV came about, there was the introduction of universal precautions. That was the first sort of real in-depth discussion about infection prevention and control. There were some things being done, but this is when it started to be formalized. And then in 87, we started talking about body substance isolation, the substances from your body and isolating yourself from that. And then in 96, we broke it down into standard precautions that you should do all the time, and transmission-based precautions, precautions based on how a disease is transmitted. And so I'm going to focus now on those standard precautions you should be doing all the time, and precautions you should take based on how the virus or the disease is transmitted. So what are standard precautions? These are a set of practices that should be applied to the care of patients, regardless of the state of infection, whether you're sure that it's confirmed, whether it's suspected. Anywhere that you provide healthcare services, hospital, doctor's office, health center, wherever. So it's what you should do, whether you suspect the case or you're sure it's a case. Standard things you should do. What are we talking about? We're talking about hand hygiene with soap and water or alcohol-based solutions. All the other things I'm going to talk about, gloves and masks and so on, even if you're using those, it does not negate the need for hand hygiene. That's a standard. Gloves, masks, full bodysuit, you still need to do hand hygiene. Use of personal protective equipment according to risk, and I'm going to talk about that next. Respiratory hygiene or cough etiquette. Cover your cough with a tissue into your elbow. Safe injection practices, not using the same needle, proper disposal, all those things that you know. Sterilization, disinfection of medical devices. Environmental cleaning, wiping your surfaces and so on. These are standard precautions. Does this look foreign to anybody, or is this what you normally do when you work? No? It's what you do, or what you should do when you work. These are standard. Whatever else you do, you must do this. Transmission-based precautions, we have three types. Contact, so if your transmission is by contact, like Ebola was. Precautions you should take if it's droplets, which is what we will do for COVID, because that's how it spread. And precautions that you would take if it were airborne, which it is not. So for us, for COVID, we're looking at standard as well as droplets, and in specific situation, airborne, which I'll tell you about. So, for COVID, if you have any suspected or confirmed case of COVID and you're treating, not with any aerosol generating procedure, regular treatment, you need standard, what we spoke about, contact, and droplet precautions. If you're doing an aerosol generating procedure, your intubations and stuff, you need standard, contact, and airborne, because now remember you are doing an aerosol generating procedure. So now it will be able possibly to spread beyond that meter. This is not just somebody sneezing and it falls. You are actually doing a procedure that is pushing it out, okay? So only with those procedures do you need airborne precautions. Once you're not doing that regular other treatment, you need droplet precaution. The other thing you need to think about is your evaluation of risk to determine what personal protection should I use. Because if I know my risks, then I will know how to protect. You have to ask myself, what's my interaction with the patient? Am I just writing their name and sending them on? I'm triaging. Am I going to be giving bedside care? Am I going to be doing an aerosol generating procedure? What is the mode of transmission of disease? We know it's droplet. Will there be body fluid generated? So these are things that will help you, the questions you ask to help you to evaluate risk. And just to give an example, how your evaluation with risk would go up. If you're collecting a blood sample, that's one level of risk. You want to not have yourself in contact with the blood. Because remember, we said with standard precautions, you're doing those precautions even upon suspicion. If somebody has come to you sick, then there's suspicion, right? If you have to take a blood sample on a patient with acute diarrhea, now you have another type of risk added to this one, and therefore your risk increases. If you have another patient, you have to take a blood sample, and they have diarrhea and tuberculosis that's airborne, you're at a higher level of risk, because now you have another disease that's transmitted another way. So you have to evaluate your level of risk to determine how do I protect. Some questions to think about as you evaluate. Does the patient fulfill the case definition for the disease that I suspect? So for example, if somebody's come to you with fever and cough, and then you ask, where have you been? I haven't been anywhere. I actually was home for the last week. Has anybody come and seen you from outside, from anywhere else? Have you treated somebody else who has had COVID-19? Then they don't have COVID-19. Where would it come from? It can't drop like manna from the sky. You have to ask the questions and determine the risk. Do they meet the case definition? Now, if they tell you something else, yeah, I had a relative, they came from the UK, they were coughing and sneezing. Okay, then your level of risk goes up. What's the infectious agent? What's the mode of transmission? What type of procedure am I going to do? Is there any risk of contamination? Where, therefore, should I locate the patients? With other patients? Not? What type of PPE should I use to protect myself? These are the kind of things to think about as you ascertain risk. So, some things you have to do all the time. Hand hygiene, regardless of PPE. And I know I'm sounding like a stuck record, but I want it to sink in. Hand hygiene. Remove and replace all damaged or broken pieces of reusable PPE as soon as you're aware they're not in good shape. So if you see your glove is torn, you still have another patient, something else to do with your patient, throw it away, get another pair. Remove all your PPE as soon as possible after you complete your care of the patient, and avoid contaminating the environment outside the isolation ward. I know Dr. Hoyt said that you will be having some training in donning and doffing of PPE, so you'll get some information on that. We don't have time today, because for you to really have that training, you have to do it. You can't just stand up and watch somebody. So you need a little bit more time. So that will come. Discard of all items of PPE carefully, and once you're done, hand hygiene again. So let's look at the different pieces of equipment. Gloves. This is used to prevent the healthcare workers, yourselves, from being exposed to direct contact with the blood or body fluid of an infected patient. Okay? So the body fluid in this instance is what the patient will cough or sneeze out. That is what will be contaminated. The gloves are to protect from getting in contact with that. However, the gloves do not replace hand hygiene. You take off your gloves, you need to wash your hands still. Gowns, aprons, this should be used in addition if there's a risk of fluid or bloods from the patient splashing onto the healthcare worker's body. You can use the same gown more than once for more than one patient, but that is if you have several patients in one cohort area and your gown has not been in contact with one patient, you can use it to treat another. So if for some reason you end up with a large number of patients and you have to put them in the same ward, that can happen if they all are confirmed cases. You don't want to mix your suspect and confirm, but all confirm or all suspect, as long as they're a meter apart, because then they're safe from each other. And you can use the same gown once it's not soiled by one patient to move to another in the same cohort. You're not going to move out from one room to the next, because then you're contaminating environment, which, remember on one of the earlier slides, that's one thing you don't want to do, standard. Plastic aprons in addition to gowns, if the gown is not fluid repellent, because remember you're protecting from fluids. So if the gown is fluid repellent, you don't need to have also a plastic apron. If it's not and fluids can go through, then a plastic apron. Your facial shields, your goggles, eye visors to protect your eyes, and if it's the visor, the mouth and nose of yourselves as healthcare workers from risks of contact from your respiratory secretions or splashes of body fluid. Medical masks. It's a droplet precaution. When do you wear it? When you are within a meter of the patient. Because why? Droplets spread. If you're within a meter and they sneeze, I mean, hopefully they use a tissue, but if they don't, you're within firing range. You should put the patient in a single room or in a room that has other patients with the same diagnosis as I was saying, or same risk factors, separate them a meter apart. Ensure the transportation of the patient to areas outside that designated place is kept to the minimum. So you want as much as possible they stay within that area, they're not going in and out for different things. As much as possible, bring whatever they need to them. Again, good hand hygiene after you remove your mask, because remember the outside may be contaminated. So when you take it off, hand hygiene. Respirators, your N95s for example. You use your respirator when you're entering and providing care for patients in an isolation facility. You make sure, of course, that it's sealed, otherwise it's just like using a medical mask. And only when doing aerosol generating procedures. If you're not doing an aerosol generating procedure, you are wasting the use of this mask that may be needed at a later time for somebody who is doing that procedure. If you're not doing aerosol, you only need a regular medical mask. Again, when you take it off, hand hygiene. Aerosol generating procedures, I'm sure you know what they are. They're just listed here, but I'm sure you know what they are. If you're not doing any of these kinds of things, your intubation and resuscitation and suctioning and these things that can generate more of the respiratory infections, you do not need an N95 mask, okay? So, I had to bite my tongue yesterday walking through the airports and all these people, passengers, N95 masks. So just a little table, okay, yeah, you can see. If we look at levels of care, so across the top, these are the different kinds of PPE you might use. Hand hygiene, as you noted, straight down. Everybody, no matter what level of care, hand hygiene. Then we have gowns, medical masks, your respirators. We normally have N95s, I think they bring in, but also FFP2s, goggles or eye protection, face shields, and gloves. If you are triaging, if your job is to triage and you're more than a meter away, all you need is hand hygiene. You don't need a mask, you don't need gloves, you don't need anything else. Because, why? We know now, Dr. explained, if you're a meter away, the droplets cannot get to you because they fall. Don't matter how hard you sneeze, a meter. About a meter. So if you know you're that distance, you don't need a mask. If you're sitting, for example, behind some kind of shield, you don't need a mask because you already have a shield. Triage within a meter. So if your triage area is such that you are sitting face to face within a meter, in addition to hand hygiene, a medical mask, because you're close enough that the droplets can get to you. If you are collecting specimens for lab diagnosis, again, hand hygiene, but you also want a gown because you may have some kind of spillage. You want to have your respirator, you want to have your goggles, and you want to have your gloves. Because if you think about now the risk, you are extracting the actual secretion that contains the virus. So that's a completely different level of risk. If you have a suspected or confirmed even case of COVID-19 that requires admission, but no aerosol generating procedure, none of your intubations on all of those, you need hand hygiene again, gown, medical mask, not respirator, because it's not aerosol generating. Just your medical mask, your face protection or eye protection, and gloves, because you're within the 1 meter, so you need to protect yourself. If you are doing aerosol generating procedure, the same as above, but rather than a surgical mask, an N95, because now you are doing a procedure that can push it further than the meter. Other persons, a cleaner who is cleaning the room for COVID-19 patients, suspect or confirm. If there's a cleaner cleaning that room, not all the cleaners, because again, you're not going to have all the cleaners rotating in and out. You'd select so that you minimize. Hand hygiene, again, that is a standard. A gown, a medical mask, because they will be cleaning possible secretions, medical mask, goggles, if there's risk of splash. So depending on what procedures took place, if there is a risk of splash, the goggles. If not, not necessary. Gloves, heavy duty, because I mean, it's more rigorous work, but heavy duty, I would imagine, is what they use for cleaning anyway. And of course, the standard closed shoes, which again, they use for cleaning anyhow. Visitors entering the room of a COVID patient, you want to minimize visitors because you want to reduce spread, so you minimize. But you can't stop. If you have an elderly person, you have a young child, sometimes you have to let people in. For me, I'm good by myself for 14 days. Netflix, bring food, I'm good. That won't happen for kids. What do you want them to do? Again, hand hygiene. You give them a gown, you give them a medical mask because they're not doing anything aerosol generating, and gloves, regular hospital gloves. Hand hygiene when they leave. Other areas where the patient may transit, the corridors and so forth, where nobody's having a contact with the COVID patient, only hand hygiene. So you have a COVID patient in one ward, and that person is not coming out into the corridor or anything. The people who are walking up and down there, you don't need anything but hand hygiene. Administrative areas, hand hygiene, because you are not within a meter even. So, hospital readiness, just quickly, I have in bubbles here different areas that you need to look at to consider hospital readiness. There is a checklist where each of these areas has its own bubble. All right. So each of the areas there has its own area, and it has some questions. And the hospital should be doing this. I know Dr. Hoyt has had it, and it's been done, to verify if you have it, if it's in progress of you getting it, or if you don't have it, so that you can ready yourself. So things like leadership, you want to make sure you've activated your emergency response mechanism. Who's the person in charge? What are the different roles and responsibilities? Very, very important thing in this instance, who's your official spokesperson? You don't want everybody talking. So somebody asks, okay, I'm going to put you in touch with Dr. So-and-so or Mr. So-and-so, who will be able to update you. Now, when you say that, you need to do so, and that person needs to call back. As healthcare professionals, believe it or not, the media holds you in high esteem and high regard, unless they think that you're lying or hiding. Then they're out to get you. So if somebody calls and you can't answer and you say somebody will call you back, and normally give them time, within the hour, within 2 hours, whatever, somebody must call. Otherwise, you leave it totally up to speculation. They didn't call. What's going on? Maybe what I heard there is true. You need to get back to them. Build that rapport. Let them come to you for expert advice and be able to debunk some of the myths and incorrect information that's going around. Make that connection. Use the media to your advantage. Then you have coordination. For example, you want to make sure that you have mechanisms for collaboration between the health services, how you get a sick person from one facility to the next. Information, making sure information comes out. I know that's been done quite a lot. Logistics and operations. Where am I triaging? Where am I isolating? So forth. Administration and finance. Make sure that you have the finance to get what you need. Administration, for example, you have your Quarantine Act that you can legally, well, the chief medical officer can legally quarantine somebody. Rapid identification so that you can have early suspicion. If somebody, your healthcare provider will know, okay, this is truly a suspect, send for a test. The diagnosis, as you know, the test can be done in CARFA. I've seen advertisements for tests up to $2,000. I guess everybody's trying to ride the wave. As far as I know, not as far as I know, I can unequivocally tell you PHAO has only provided the appropriate reagents, the probes, the primers, and controls to CARFA in Trinidad and Tobago, who will do the test free of charge once they have a true suspect case. They will not test every flu and sniffle, misuse of resources again. But once you as a healthcare provider have ascertained this is a suspect case, at this point in time, they will be testing for free. Isolation, making sure you have your areas, proper case management, that you know what you're doing, you have the medications, and so forth. You have your, for infection prevention control, you have your PPE, you know how to use it, and so forth. So there is this checklist that Dr. Hoyt is going through, just checking off to make sure that the hospital is ready. You have everything in place that you can identify and treat with patients as need be. So in summary, the use of personal protective equipment by healthcare workers, in fact by anybody, requires an evaluation of risk related to what you are doing. And that will determine if you're using just standard precaution, standard and droplets, standard and airborne. So again, this is reiterating the slide before. For suspected or confirmed cases, if you are not doing aerosol generating, standard contact droplets. If you are using airborne generating procedures, standard contact airborne. Last but not least, stay informed from reliable sources. I know you're busy, but you hear something, you're not sure if it's true, go to one of these websites, WHO, PHAO, Ministry of Health. Whatever is there is validated and verified information. So keep yourself informed. Don't let people fool you. Thank you for your attention.
Thank you.